Marson is a professor and vice chair for research in the Department of Pediatrics at the UC Davis School of Medicine and director of the Center for Health and Technology at UC Davis Health. Completed medical school at UC San Diego, pediatric residency at UCSF, and pediatric critical care fellowship at Children's National Medical Center in Washington, D.C. In addition to his clinical work in the pediatric ICU, he conducts research and advocacy in telehealth related to access and quality of care, particularly as it relates to children with special healthcare needs and acutely ill and injured children in rural communities. And from the title, from neat to necessary, that kind of sums up so much of what we've done over the years, with telehealth being kind of almost a side gig for a lot of providers and on their own time. And many of us worked to try to make it more mainstream. And all of a sudden, in March, it really became mainstream very, very quickly. So please welcome Dr. James Marson.
Thanks so much, Dr. Spalding. Let me just go to the share here. And hopefully you all are able to hear me and see the slides up, right? Okay, thank you very much again, everybody. This is super honored to be invited to speak here. A lot comes out from your state and your region on telehealth, and you're among rock stars, so it's a big honor to be invited to this conference. So thank you very much. Hopefully you can see my sign here. Again, just as Dr. Spalding had mentioned, it is going neat to necessary. I've been complaining for years that we should be doing this and we should be doing that with telehealth, and now with this unfortunate pandemic going on, all of my bosses are saying, why aren't you doing this and why aren't you doing that? And so I kind of long for the old days of sitting back and complaining about what we should be doing. Now it's forced upon us to be doing it all. And again, thank you very much. I'm really, at some point I'll get out to KU Medical Center and visit my colleagues there, because it's a bummer not to be able to travel out during these times. So telehealth, as we all know, it's all about access to care. I think that that's a primary core reason that folks want this. Yeah, there are benefits to the doctors and the providers and the nurses and the efficiencies and even cost savings that could be argued for. But I think the primary focus behind it all is patient-centeredness and access to care. And again, from my world in the pediatric world, this is a map of the United States clearly with an orange dot around the children's hospitals, those that are registered with Children's Hospital Association, and a 16-mile driving radius. And the fact of the matter is that 23% of all of the children in the United States live more than an hour from a children's hospital. And you can see there's spaces, including in the Midwest with Kansas, there are long distances that children don't really have the same access to care that those that might be living in urban areas with care. So we don't necessarily want to change that model of regionalization because we know that it improves efficiency and quality, right? It doesn't make sense to have a children's hospital or a trauma center at every street corner hospital because there will be low volumes, they won't be efficient, they won't be able to maintain the quality. But the model of care of regionalization, again, in of itself creates disparities in access. But in a way, telemedicine, telehealth can leverage the benefits of regionalization, but still be able to provide the expertise everywhere. And then just it puts the model of healthcare on its head. Rather than folks going to see clinicians, doctors, or nurses in their office, it's able to provide the providers to the patient wherever they might be. The overriding principles for us, and I know for you as well, is that we have to kind of like not focus on the technology, not be wowed by the gadgets, not be excited about new devices and things like that. We have to really focus on medicine being medicine, and telehealth is a care delivery model, and it's more about workflow and operations rather than it is about the technology. And again, when the doctors come to me and ask me like, well, would this be appropriate for telemedicine? Would this be appropriate? I go back to them, you're the clinical specialists, you're the clinical teams that are providing care to these patients. You tell me, you're the one that would know, do you need the patient in person? are you able to do this over video or audio for that matter? In many instances, the comparator, sometimes people say, can we provide the same level of care as if the patient were to come to us in our clinic office? But oftentimes that isn't the right comparator. Lots of studies have looked at that. Can we provide the same level of care when they come to us? But a lot of times it's a patient not getting care at all. So if they're given a choice between traveling long distances for care, or even if it's not a long distance, but it seems to them not so important for a patient, telehealth all of a sudden is rising the level of care from no care to what it is you're able to provide over telemedicine. For those of you that do telemedicine, as many of you know, you can do a physical exam and much more. There's been several pieces published in lots of different journals about the realization that as providers are doing this more and more and seeing patients in their home environment, in their homes. Last month, from my pediatric endocrinology colleague, she told me that she was able to first recognize a couple of her patients were homeless, that she wouldn't otherwise know, so that she was connecting to them and recognized the fact that they were connecting from tents, but she wouldn't have otherwise known this because otherwise they were coming to her to see her in a clinic. So there's actual advantages that way. And it isn't always appropriate, right? So when the doctors say, hey, I think that the patient should see me, or the patient prefers an inpatient visit, we really try to never force the use of any of these technologies on either the provider side or the patient side. And again, long-term strategy of your healthcare clinic, your healthcare institution, your practice, whatever it is, it shouldn't be sacrificed, and telehealth should just be used as a tool to be able to implement your long-term strategy. Lots of benefits, again, for those of you that I'm a little bit preaching to the choir here in terms of improving access to care. It certainly can address distance barriers. In some ways, it can provide shortages. I know that the theme for this meeting has to do with workforce, and I'll get to some slides at the end of my talk about this. And we know that there's a lack of healthcare providers, behavioral health, physician, nursing, all across the country. And in some ways, telehealth can address this. Again, I did mention the patient experience. I think that is very patient-centered, convenient for users and consumers. In some instances, it can improve effectiveness, efficiency, and quality of care. Not all the time. Sometimes it's less efficient, in particular when there's multidisciplinary teams involved with the care. Again, I'll use endocrinology as an example where you're going to be talking to a nutritionist, a social worker, a case manager, a physician, the dietitian, all of those different teams of people. That's hard to replicate when you're doing it one-on-one over video as in person, where you can all be in different rooms that way. But we're trying to figure out new technological ways of addressing that to improve the effectiveness. And then value of costs of care. And again, I think that the overall thought is that the use of these technologies not only will be cost savings for the patient, not having to travel distances at our institution, having to pay $12 to park, things like that, but also on the healthcare side as well. And again, wherever healthcare is delivered, outpatient, inpatient, urgent care, chronic disease management, palliative care in schools, nursing facilities, home, all of it, there's technologies for all of these to be able to deliver the care this way. So I'm a little bit bummed. I apologize for not having set this up on the poll everywhere survey. I was going to chat with Dr. Spalding to see if I could do this, but we can just do this without the poll everywhere. But the question is, who or what is the greatest driver of telehealth in your healthcare institution? Is it A, the CEO? I'm not sure if he or she is participating on this call. Is it your chief information officer? Is it your chief medical information officer, CMO or CMIO? Is it your chief innovation officer here? Or is it the COVID? And I think the point of this is, I think most people would say the greatest driver of telehealth at their health system, institution, or clinic has been COVID. And no offense to all of you C-suite folks, but COVID really did it. And again, I think that I've seen lots of people share slides like this. We were very fortunate at UC Davis, and I'm sure that some of your institutions were fortunate to have the infrastructure in place. If you didn't have the infrastructure in place, I'm sure that you were scrambling to figure it out. But for our video visits, that is the direct-to-patient care, you can see on this graph on the lower right that we were about 50 doctors were regularly participating at this institution, despite my cheerleading, gift cards, bribery, threats, all of these things to try and get it. And at my institution, I'll be honest with you, I had from my boss to get 1% of our 1 million outpatient touches to be done by video visits by June of this year, and I was sweating bullets in January and February. Then COVID came, and again, this is a horrible pandemic, and not to make light of it, but anyways, I'll be able to get my $25 bonus by the end of the year just because as you can see, we were doing more than 1,000 video visits per day. And I have another slide to give that relative, but we are up about 60-70% of all of our outpatient touches being done by video visits. And again, that has settled down over time as we're bringing people back. But we were also very quickly able to up-ramp teleinterpreting involved so that we can have three-way calls with the interpreter. We were able to do internal approaches to say for PEE, so doctors, clinicians, nurses were able to check in on the patients in the room if they were COVID positive, for example, using telehealth technologies. Integrated all with our electronic health record, IT, and it really was able to come quickly part of normal operations. A lot of that has to do with the structure of our organization, and this is not to say that this is the right way, but I like hearing about how other clinics, practices, health systems are set up, and how they view and support and integrate telehealth in their health system. And so for us at UC Davis, it's a core group of people. And again, I'll be transparent with all of this. Before COVID, we are about $1 million a year operation, our Center for Health and Technology, the support staff to run telehealth. Post-COVID, we're one of the divisions that our budget has increased, so now it's nearly $2 million. But what we do is not in a silo at all. We very closely, a gazillion meetings, are working with our clinical operations team. They're probably the most important teams to get this up to running to full scale. We have regular meetings with our medical staff, talking about credentialing, privileging, training of the docs on telehealth use. Big frequent meetings, of course, with IT, EHR. We are an Epic shop here, so lots of meetings of how to integrate this and make it a better experience for the patient and the provider. We meet regularly with, of course, with compliance and billing. Lots of questions about what do I need to document? Am I going to get paid? Things like that. And then lots of very sharp nurses, doctors, faculty that come up with ideas on how to improve the process of care, again, for both the patient and the provider with research. And we kind of help coordinate that through our telehealth center. And then when there are agreements with outside institutions, hospitals, clinics, things like that, legal and contract. And again, this is not mentioned to say that this is the right way, but to say that we have found some success, not being our own entity, but unfortunately having lots of meetings with lots of different players. And then once a month, we all come together for a really big meeting. And in our portfolio, and again, this is what telehealth can be, not that this is the right way to have categories or the wrong way, but we have been for many years providing outpatient subspecialty telehealth. That's been mostly to FQHCs, RHCs, and Indian Health Service sites, from our specialists to the clinics outside, where the patients can go to their regular PCP and get these subspecialty consultations. Again, we've been doing this for years. We have 30 different specialties that actively participate in this, and we connect within a year about to 80 sites. And again, there's places that do a lot more and a lot less, and please don't take this as bragging, but it's trying to, and again, probably with KU, it's embarrassing to share these numbers because you, I'm sure, do a lot more, but it's just good to share what other folks are doing. We also do some inpatient specialty telehealth. An example of this is telestroke, teleemergency, where our inpatient specialists connect with hospitals, community hospitals that may not have access to those specialties. And again, we're about 35 sites, 10 specialties there. I mentioned previously internal inpatient telehealth. That includes interpreting, connecting families with patients, especially now that they're isolated and visiting. There are visitor restrictions on place, family engagement. So when we're doing discharge planning discussions with the patients now, we're actively trying to get all family members that might be interested in participating and hearing these conversations on a video link inside the patient room. Can we use Epic for the MyChart video visits? So these are this primary care or specialist directly to the patient home. And again, this is something that was at 1%, went up to 60%. It's come down to about 30% of our outpatient touches right now. E-consultations, we have that in our Center for Health and Technology. It may not be telehealth, but again, some specialists requiring that from the PCPs before having a patient referred to them in person. Others where it's elective. Our health system has been financially supporting these with additional RVUs and payment to the specialists to kind of get us over the hump that way. And then again, so we also, for acute care video visits, that's another category. And we have been and still continue to a certain degree outsource this, right? So there's lots of companies that, not to pick anyone in particular, but American Well, MD Live, Doctor on Demand, Teladoc, lots of companies that will provide acute care video visits that I'll talk about. And we're in the process of internalizing that with our own providers. A lot of times it makes sense financially and resource-wise to outsource that. And then we have a team, a group of people working on remote patient monitoring or chronic disease management of patients. Again, COPD, hypertension, diabetes, and the gastric, the surgery teams are involved with those with remote patient monitoring teams. I'll have to say that we don't do a lot of that. When I hear lots of different health institutions plans, especially integrated ones like the VA or Kaiser, they do a lot more remote patient management than we do. We're still a little bit transitioning from the value or from the volume to the value-based healthcare. And I think that as we move that needle, we'll invest more in the remote patient monitoring and chronic disease management. And then the last thing that's very important for us at UC Davis is the research, education, quality improvement around telehealth. And so we pride ourselves in having junior faculty members from the School of Nursing, the School of Medicine, doing research in telehealth on ways to improve the delivery of healthcare using these technologies. So this is another slide kind of to see where we sit in our institution. Again, lots of great ideas coming, research QI. It starts with the ideation concept of how we can use these technologies. We have kind of a dry lab or digital health resource center here, or what we call a sandbox, where we test a lot of these initiatives. We will work with clinical operations, IT, Epic, everybody else on early implementation. And to be honest, then we kind of like, we're done with that from the CHT standpoint, because this is just part of routine care. And I mostly say that we're that way right now for video visits. That's not, it's partly followed by our telemedicine group, but right now the clinical operations have taken over that. And again, from our health system standpoint, for us, that makes a lot of sense. This is data from all of the University of California health systems. There's 10 University of Californias, 5 health systems within there. You see San Francisco, San Diego, Davis, LA, Irvine, and Riverside. And the orange bar is what they were experiencing on a weekly basis. And of course, it goes down at the on the weekends. And then the dark line was video visits. Then COVID hit here. And for some time on a UC-wide level, you can see that total visits are down, but there was a majority of them being done by video. And I apologize, I couldn't get the more recent data for this, but this is continued on. The total volume has increased to probably about 80% what it was pre-COVID in terms of outpatient, with about 20% of them being in video. And it's hard to say where that should end up, but some people talk about that making a lot of sense at 20% if you believe in the fact that in many cases, if it's a post-op surgical check, a medication check, things like that, that those are very appropriate for a video visit. So we didn't anticipate them continuing to be a majority, but we don't want it to go down to 1% like it was prior to this. This is from Fair Health. It's a not-for-profit, if you have those of you that are familiar with it, that track kind of and display CMS funding. And they've been tracking the use of telehealth. And up in the upper right here is what I wanted to draw your attention to. So I selected the region that Kansas is located in here. You can select different regions of the United States. And during the month of April, and this may be higher for May, May date is not out yet, but basically 11% of all claims to CMS were for telehealth. And on these great interactive, this website, it talks about the different CPT codes. This is 2019 on the left, 2020 in the purple there, the different codes, and the distribution in graphs in the lower right, again, in the lower left, again, from 2019 to 2020. So you can see, and there's been an enormous increase in use of telehealth across all aspects. Mental health, of course, continues to be, mental health and behavioral health continue to be the #1 use for all telehealth visits. We like to claim that it is excellent for urban populations, or for rural populations rather, but in terms of overall volume, more of it is still being conducted in urban settings, probably just because of the higher urban populations this way. But for those of you that are interested in looking at it on a national CMS level, I highly recommend looking at Fair Health. This is another piece of data I got from the National Association of Community Health Centers for those of you that are in RHCs, FQHCs. They similarly went to about 50% video visits during COVID. And this was a survey that was conducted in June, a national sample of community health centers. We know, because you have an amazing telehealth resource center with an amazing team in your region, the changes that have happened. A lot of it, I like to say, is literally lifting of restrictions, right? So there were what I would consider restrictions that had been lifted given COVID. And then in other areas, maybe a little bit gifts have been given. Like, for example, allowing telephone visits to be reimbursed the same as video visits. I mean, there's good reasons behind that, but I don't know if I would necessarily consider that a pre-existing restriction. So to just go over them quickly, there has been an extended list of providers that can provide telemedicine and that are doing telemedicine, and a list of eligible services. And again, you can get this off the CMS and your state website, all of the different codes and services that are now reimbursable over telemedicine. The obvious one, of course, is the lifting of the originating site where the patient is. So now CMS, that was a big issue for us pre-COVID, is that those patients on Medicare, technically you couldn't get paid for doing a telehealth consult while they're at home. Now you can. There's also been lifting of the distance site, so the provider can also be at his or her home. We're familiar with the lifting of technology requirements, the waiving of the HIPAA enforcement. Our institution has really tried to continue to use HIPAA compliant mechanisms and connections, but this has helped a lot of institutions that may not have had the infrastructure in place prior to COVID hit. And then a lifting of cost sharing requirements. So there are, I'm following it in the news, and you probably are following it as well, and I'm not sure in Kansas, but several health plans, commercial health plans, that are reversing this now, saying that they've considered this to be a temporary implementation. There's a couple of health plans, at least in Texas, that were starting to no longer follow these guidelines, given that COVID in their mind was reaching a steady state. I anticipate that they'll get heavy pushback. And as Dr. Spalding mentioned, there are efforts and in Congress to be able to maintain at least some of these, including the originating site for Medicare patients to include their home. So we're fighting with a lot of others to keep the restrictions that have been lifted to be off. And again, a call out to your telehealth resource center there, Dr. Evelyn Nelson and Janine Gracie, amazing people. I've heard them both speak, as well as Dr. Spalding. You have a rock star team in your region, and they have amazing resources. Again, I was just reviewing what they have, and I'm honestly jealous of all the resources they have compared to our telehealth resource center in California. Is this being recorded? I might get in trouble. And then there's also the Center for Connected Health Policy there. That's a national telehealth policy. If you have telehealth policy questions. So there's lots of resources out there for those that have questions regarding implementation, documentation, regulations, and such like that. So because I'm a pediatric critical care physician, I've spent my career doing teleemergency as a model of care. I guess this is a little bit painful for the audience, but I'm taking speaker prerogative to talk a little bit about the programs that I've worked on and trying to connect to emergency departments in rural and underserved communities with pediatric emergency medicine, trauma, critical care specialists to raise a level of bar for sick kids that go to emergency departments. We've done some studies to demonstrate that the parents are happier with models of care that follow this, that the ER doctors are very happy with when video is used compared to the telephone. We've done some measures of quality of care using an implicit review instrument to demonstrate that quality is higher when video is used on these sick children. We've had pharmacists look at the data to demonstrate that the medication error rates are lower under these circumstances and fewer inappropriate transfers. And I've deleted some slides that I've sent out before, but we just completed, with a lot of blood, sweat, and tears, a 4-year study, randomized trial of 15 different emergency departments, whereas randomized crossover trial of critically ill children, and have about nearly 700 patients enrolled in this trial. We're writing this up for a publication. And we knew that telemedicine wouldn't always be used, so we waited at 75% of the time for the patient to be weighted for telemedicine. And in the lower left, you can see when they were assigned telemedicine, it was actually about 43% of the time that they received it versus 56% of the time where they got telephone. But also in some circumstances where the patients were randomized to use the telephone, either provider on the emergency department or one of our providers opted to use telemedicine. And just very quickly from our results, these are the odds of transfer of the child were 0.42 when using telemedicine versus telephone. And the premise here is that when we connect with the child, and if they're calling from a rural site, they're more likely to transfer, and that's probably the right thing, right? You want to err on the side of safety with this. But we were able to hopefully reduce those inappropriate transfers and give guidance to keep kids and families in their local community with this technology, with a number of needed to treat of 12. So that is, we had to see 12 kids over telemedicine to be able to save one child from being transferred. We also use it out of our newborn nursery and labor and delivery unit. That's a very common use for our telemedicine program here. And I think that I set it up that you could get audio here if this plays. This is a 12-year-old video that I just wanted to show.
Okay, I'm not going to be able to see if everybody's clear.
2 hours up north with SVT. And we're going to shock the
Let's
baby.
charge it 2 joules.
Our doctor's in her office, so watch the baby.
Whenever you're ready.
And shot.
And so that's just 2 joules. And there's our doctor in the office. And he went from normal sinus or SVT to normal sinus
Okay, that looks
rhythm.
like sinus.
Mostly I just like showing that video because the baby gets shocked. But and then I joke, it's hard over Zoom, you know, that I shock my kids at home more like with 10 joules if they don't make their bed. But jokes like that, it's just hard to do over Zoom, and they're probably inappropriate. Anyway, so the future of telehealth really, I think, is going to shift. We've done these video visits, but it's going to be to chronic disease management. We all know that 25% of the population utilize 75% of the costs here in healthcare costs, and it's all about comorbidities and chronic disease management. The silver tsunami is here. There's lots of applications to be able to use here. The 5 largest health plans in the United States, all of the large pharmacies, all of the large retail stores are getting into this game. And this is really where the future of medicine is going to take, or telehealth is going to take the future of medicine. An example I like to look at is the VA. Again, they are very vested in this because if they're able to save $1, that's $1 that is saved in their pocket. 45% of vets live in rural areas, and they have a lot of experience on knowing what works and what doesn't work. And so 20% of the vets use telehealth in 2019. And they didn't have more recent data, but they have about 3 million vets are using their mobile device connected app to be able to get care this way. So I think that in a lot of ways, we kind of like, or we look at the VA on what's working with chronic disease management and remote patient monitoring to help give us an idea of where it's going. And then there's also talk about using hospital to home. Should have blocked out the user here, and we've started to do this on a pilot case here. You might be doing it at some of your healthcare institutions there when our hospitals are getting full, like they are right now. Sick patients can be sent home and be monitored, whatever, pulse ox, I can get respiratory rate, heart rate, things like that. We don't have all of this figured out on how that's going to be monitored, how the alerts are going to go off, who's going to be watching this data, how is it going to be integrated into Epic, EHR, but all of these are certainly a part of the future. The kind of the thing I wanted to talk to you now was about to direct consumer telemedicine. That is something that has certainly exploded pre-COVID. It was the biggest increase in use of telemedicine across the country, right? So you can connect with one of these applications or private companies and be able to connect to a doctor from the convenience of your own home. And for me, this has been a particular area of interest in looking at the research. And all of the health plans all of the major health plans in the United States offer this, right? They, in their mind, if I can have a patient see a provider over video or over phone and have them not go to the emergency department, it's going to be a win-win-win. I'm going to save dollars. The patient's going to be happy for convenience, and we'll save the resources here, right? And it's all about cost savings. Online visits are much, much cheaper than any other type of care. While I'm very, very supportive of this model, I'm going to talk through with a number of slides coming up about the issues that are related to this type of care. So this is, I'm not sure if other providers get these emails. I do. Emails that say, hey, come join our team. We can treat flu, all of these different issues, pediatric issues, adult issues. And it comes with this, that's hard to read, but it says basically earn up to $100,000 a year in just 2 hours a day. And I'm like, who the heck would want to do that? So these companies are kind of swooping up providers to sit on video calls to see urgent care patients from across the country. But again, I'm going to go through a bunch of data to draw caution regarding this model of care. So there's been lots of studies when people call in, is this high quality of care, and are we doing the right thing, right? Yeah, it makes sense that it could be convenient for the patient. We can address it over video. They don't have to come to the office. That sounds like win-win-win. I'm going to burn through a couple of studies. So when women were calling with dysuria or a painful urination, this is one of the earlier studies. The frequency of urinalysis on the left side was down at about 13%. In standard of care with dysuria is to get a urinalysis. You want to know what's causing it, if it's bacterial infection, and if it is a bacterial infection, what type of bacteria it is, what antibiotics it's acceptable to that way. And then antibiotics order. You can see in the clinic about 50% of the time they felt that antibiotics were not necessary. Perhaps a urinalysis was negative and it might have been something else causing the painful urinalysis. But on the e-visit, basically it was all but one patient got antibiotics. So this quality of care is an issue here. But the data on this, they did a cost analysis. It was cheaper to do the e-visit. Why? Because you didn't have to do the urinalysis. You didn't have to do the culture. And antibiotics, frankly, are quite cheap. So if you're a health plan looking at this, are you going to look at the quality there, or are you going to look at the costs of care? And I don't have an answer for that. So there's lots of other studies. Again, this is one that looked at 4,600 e-visits, and they looked at the frequency for using antibiotics or avoiding use of antibiotics, which you're supposed to do for bronchitis, and whether or not they were testing the throat swab for strep with uncomplicated pharyngitis. And again, as expected, they're unlikely to do the testing, and they're more likely to prescribe antibiotics when they're done over video visits. Another very large study, 13,000 patients, American Well, now known as Amwell. They looked at all of these studies for upper respiratory tract infection. Their average length of video visit was 6.6 minutes. Patient care, among those are the patients that got antibiotics. So you could, as a provider, you can get on and off a call, prescribe antibiotics in an average of 6 minutes. If you didn't think antibiotics were warranted, that took a longer time as expected, because you'd have to explain why antibiotics weren't warranted. And so it was a longer time. And then the doctors get rated on this for quality by the patient. And you were 3.2 times more likely to get a 5-star rating on these apps from the patient side when you give antibiotics. Again, this is not necessarily the right incentive. So providers being incentivized time-wise, pay-wise, and their rating-wise to oftentimes not do the right thing, which is to give antibiotics. So I showed another study that, and again, the idea is that we're going to avoid care, avoid patients going to urgent care and in the clinic. And I do want to mention that was a big study done in Health Affairs that looked at this, and they thought in their study, they determined that 12% of these video visits actually replace an urgent care or ER visit. They actually estimated that it replaced only 8% emergency visits. What they concluded was that actually it just created easy access and 88% new utilization. That is, in their study, when patients were given the opportunity to connect to a provider on their mobile app, on their phone or whatever, yeah, it saved a little bit of them going to the emergency department, but mostly it created new utilization. So they had it so easy, they would connect to a doctor that otherwise they wouldn't do anything about. They would probably just wait it out. And in their study, it added overall costs. And I think that this had to do with, this is a respiratory tract infection, so they just had to, they prescribed antibiotics here. And in the urinalysis test, there was additional testing that needed to be done with the urinalysis and the urine culture. So that might explain why some studies find an increase in costs using telehealth video visits, and other studies might find a reduction in costs with telehealth video visits. Again, more studies. Again, this was done on pediatric patients. When you give antibiotics, and it's a stepwise thing, that if you saw direct to video, you would give antibiotics 52% of the time. If you're in urgent care, it was 42% of the time. And in a clinic visit, when you actually saw your pediatrician, it was only 31% of the time. Not that antibiotics aren't warranted many of the times, but oftentimes they're not. So just their concordance to the appropriate antibiotic management isn't always the best. So again, I've talked a lot about negative studies with this model of care, and that my point is to not say that it isn't good or doesn't have a place. It certainly does, but we have to have research, and we have to kind of figure out a little bit more what we're doing before we offer this to the masses. And it's really going to come down to going from volume-based to value-based, and who's saving the money, right? So if it's the health plan that's saving the money, they see a cost savings associated with this. Even if more people are getting antibiotics, what are they going to choose? So again, not much about this. So I'm going to just continue on a little bit more with this current theme before I get into workforce, and then I'll be done. But I've become a little bit addicted in my old age to negative trials that I find interesting in telemedicine, because before I was like a lot of people, this is the greatest thing since sliced bread, and we can use it to get patients that don't have access, which is very, very, very much true. But I do want to advocate for the fact that more research is needed. This was published in I think it was JAMA or JAMA Internal Medicine. It was called the IDEA randomized trial. And they had overweight adults with a BMI between 25 and 40. And it was a great trial, two-year study. All of the patients received a low-calorie diet. They were prescribed increases in physical activity. They all had access to group counseling sessions. So they all had this. And then at 6 months, half of them got basically a Fitbit with instructions on how to use it, and goals actually about how much how much activity they're supposed to be able to do. And the idea is like, hey, you're adding this technology, Fitbits, right? You count how many steps you have that you're going to do better. What did they find? Well, the control group without the Fitbit after 2 years lost more weight than those with the Fitbit. You can see there, it's not, these numbers, it's like 6 kilos, 3.5 kilos, statistically significant, right? So each kilo is 2.2 pounds. So 15-pound loss among the control group. I'm shooting from my hip here, and about half of that in the intervention group. So I'd say opposite of what researchers thought and or were hoping to find. The editorials were pretty funny. I threw out my Fitbit once I read this, because I found myself, they were saying, well, people, they do so many steps and they're like, oh, well, I can have a donut now or a second dessert. And I was doing that same thing with my Fitbit. And so this was an interesting study, I thought. Another study, I'm not sure if any of you use in tele-ICU. So there's lots of research on tele-ICU, and I do think has a very good place in use in rural ICUs that can't be staffed by critical care physicians. They looked at this out of the Mayo Clinic, where they connected to 6 community ICUs out of Rochester. And after studying this, they found that there was no change in mortality, no change in length of stay. And all these telehealth connections did was result in more transfers to the Mayo. So they would connect to a rural ICU and they'd say, oh, you need to transfer that patient to us. And they would end up doing that. So overall cost for the patients and healthcare went up with this model. And again, I'm not saying that EICU or tele-ICU is a bad thing, but it's so variable under what circumstances people are implementing these activities. So we were very big also with the congestive heart. This was a multi-institutional trial. 6 health systems, UC Davis participated in this, nearly 1,500 patients with severe heart failure. And this is the same thing where everybody had health coaching, telephone calls, and then half of the population got some telemonitoring with daily blood pressure cuffs, heart rate monitor, an online symptom checking, and a Bluetooth scale, congestive heart failure patients, right? The idea is that these digital monitoring of this patient will be able to allow us to interact more quickly with these patients and identify issues. Anyways, this was in JAMA Internal Medicine, a negative trial, no difference in readmissions, no difference in mortality. Again, not trying to say that home monitoring of patients with chronic conditions doesn't work, but we have to be very thoughtful. Maybe it was that the patients weren't appropriately using devices, participating. There were subsequent sub-analyses along this line. And we did find that patients that actually did participate with the symptom checker and weight gain, they did have a reduced readmission rate, but overall, in a realistic randomized trial, no difference. So, and again, this is, forgive me, so I'm a researcher, and so I think that research is, the most important thing since sliced bread. So forgive my perspective here, but there's lots of metrics that are out there where we need to be able to study these. And I do think that in lots of ways, telehealth is doing amazing things, and you don't want to be left behind. You don't want to leave your patients behind if it's a convenient type of care, but lots of thought has to go into it with technical, IT, nursing, caregivers. Everybody has to have a seat at the table when you're evaluating whatever it is type of intervention that you're wanting to do. And NQF has things, AHRQ has studies like this. And then and this is my wrap up before I just talk really a few slides on healthcare workforce, things that I hope you hear. I am an advocate of telehealth, despite my biased presentation of lots of negative trials. There's lots of increasing applications. Of course, there are barriers, things like interstate licensure, credentialing, payment, parity, all of those things. Consumers, I think now, even more so than ever, are going to demand it now that they've had a taste of it. We've heard that on our Press Ganey patient surveys, that they want to be able to continue, especially those living in rural areas and those with conditions that are amenable to video visits. But the last bullet is my biased opinion that lots of research needs to be done, and there's still change management done, right? Everybody is busy. There's not a doctor or nurse thinking, oh gosh, I wish I could see more patients today, I'm kind of bored. So offering them telehealth isn't going to work just like that, right? So when I was doing my teleemergency study, I with my colleagues, and these are my colleagues, like my friends, I have 15 folks that I work with in the pediatric intensive care unit. I'm like, hey, email me when you're doing telemedicine consultations so that we can get the patient enrolled and things like that in our trial. And I like to share the email message I got from my colleague. He wrote fracking, so I did another fracking telemedicine consultation. I blocked out fracking because in California we don't like fracking, but again, and then he went on to say, actually, just looking at them after the telephone consultation, he wrote, is it really that bad? He meant it really wasn't that bad to do telemedicine, but it's change management. It's having folks do something different when they're already very, very busy. That is a challenge for all of us. And so it's going to be teams of people to be able to do this effectively. So quickly, I think I have 4 more slides, and it has to do with the broader topic of and I'm going to stay on. I'm very much looking forward to this conference with all of the fabulous speakers that you have with workforce. So I've been on the committee for pediatric workforce for a number of years. I just rotated off of that, and I'll get to a policy statement that we shared. People ask, can telehealth help address the workforce issue? And I don't have a really good answer to that, because it's not just the telehealth, but it's going to be how it's going to be implemented, right? If you just add more clinical activities and greater access to patients, that's not going to work. Folks are busy. There's got to be collaboration with advanced care practitioners, technologies that are able to screen data and present it to our frontline provider clinicians in a better way. So there's lots of things that will have to go along with telehealth, remote patient monitoring, easy access to care for it to be able to help make the shortage of healthcare providers any better. So one of the things that we started looking at here at UC Davis, we're embarking on a study now that there's lots of studies to look that there are lower levels of provider satisfaction, unfortunately, among family physicians working in community, isolated rural community health centers. And we do know that lower levels of satisfaction are associated with higher turnover and declining healthcare provider supply in rural areas. So that's true across the country, right? Retention of these very important providers is sometimes very difficult in rural areas. And we like to think that telehealth can help with that. There have been several studies, and I have a list of them down here, that have suggested that when you have telehealth connections with regional centers, with colleagues, where you don't feel so isolated, where you can help your patients more readily and easier, that's going to ultimately result in better patient follow-up, better access to care, and lower turnover rates. So we're going to start a study here at UC Davis where we're surveying a whole bunch of rural FQHCs about access to telehealth. And there's something, a provider stability index that looks at provider doctor and nurse turnover in those clinics to see if there's an association with telehealth, and to help see if telehealth can help stabilize the workforces there. Again, I was part of the Committee on Pediatric Workforce in the American Academy of Pediatrics. We came up with policy statements. I'm going to just kind of burn through from our advocacy standpoint. There are 10 policy statements that we came up with. And again, this is nothing new, but it's something that we can take, and I have taken on a bulleted form to our local legislators here in Sacramento on California to talk about, hey, this is what the AAP is advocating for in terms of the reduction of the barriers to telemedicine, parity in payment, which we hope will stay in place post-COVID. That is a real issue, of course, I'm starting to get tangential here, but patients that may not have access to cellular phones or mobile devices or good Wi-Fi, right? We don't want to discriminate against them. This is supposedly a tool to help address those that are in rural and underserved communities, and for it to do the opposite, to create a disparity in access because they don't have that. We don't want that to happen. We do feel that the care is very important to be done inside the medical home, right? And so that's why we're trying to, rather than farming out our acute care visits, but bring them in internally so that our providers are doing and have access to their medical records. We're supporting stable funding, research, of course. We even went so far to say that there should be financial incentives because doctors, clinics can invest in these technologies to keep their patients healthier and add to the clinic, but that results in less revenue. So who's going to want to do that in the way that our models, our healthcare payment models are set up currently? So there's lots of changes that have to go along with this. And then my last slide is my nephew. He went to KU, played baseball there. That's him, and he's in the Marine Corps now. He was a pilot, and now he flies these enormous, I don't know what those are, but these enormous, he's in the Marines and stationed in Hawaii, but a proud guy. And I've been out a couple of times to KU to visit him. And again, I just wanted to thank everybody very much for the opportunity to speak to you today. And I'm very much looking forward to enjoying the rest of the conference. Thank you so much.
Thank you so much, Jim. I had no idea that your nephew went here. That's the biggest surprise of the whole talk. That was great. So we have just a time for a couple of questions. I saw one come through the chat that I just wanted to mention, Jim. Maybe you could address this. Is there a concern about antibiotic overprescribing on direct-to-consumer services? And if yes, how can this be balanced with a test ordered at a local urgent care or hospital?
So yes, there's an absolute concern, and every data element shows that antibiotics are overprescribed when they do it over video. I have some colleagues that work with these companies, and there's honest efforts. They recognize that that's a problem. They recognize the bad research, the bad press that they have gotten so far. And so they have QI improvements. I've talked with one of the guys who's the medical director at one of these big direct-to-consumer companies, and they actively are now tracking the rates of antibiotic prescriptions given the diagnosis, and they're hammering on their providers, and they're called if they are outliers in overprescribing antibiotics this way. So just like clinicians have been hammered in person in the hospital, in our clinics that way, they're starting to do a better job. And again, I think that if we're able to produce data to show there's issues, then I'm hopeful that they will begin to address those. So they're starting to work on it internally.
Very good. We maybe have time for one more question. Does anyone just want to ask a question verbally? Donna?
Yes. This is about the AAP recommendations and children with special health care needs. From a family engagement perspective, are there any considerations regarding digital health safety as families start integrating all of these apps into their personal devices like Fitbit software? As health providers encourage those things, who is educating families on potential software data mining from the app authors?
Oh, golly. So that is a great question, and not enough is being educated for sure. Now, I'm sure that you have expertise that can answer this question better than I. My impression in working with, I'm also on the, there's a AAMC thing where we're coming up with on what should be taught medical students, residents on telehealth. And this is one of the big points, is talking about security of data and data mining. I think in the healthcare systems, we are very conscientious about that, and we are very thoughtful. We have HIPAA. It is probably, not to pull out the names, but the Apple Watch, Apple, Google, Amazon services, they have a lot of data that healthcare systems, healthcare clinics would never think of having and of mining. And so in a way, it's my perspective is that there needs to be more education. There needs to be more patient privacy advocacy on that way. And again, maybe this is me just being protective as a healthcare provider, but I do think that we are very conscientious and we do a good job in the health system walls. But it's outside the health system walls where there are high risks to privacy. Again, I didn't even realize this, but I just saw this week on my Apple thing, it somehow connected with my chart, and it knew what medications I was taking and things like that. And so it's scary.
That is scary. So thank you for the question, Donna, and Jim, again, for the presentation. Just a reminder, everyone, the presentation that Dr. Marson just provided will be replayed at noon as our normal monthly webinar. It'll be the recording. So Jim, we did record it. So it is all going to be out there. So, but the email that you got was also, that was the second biggest surprise, I think, of the presentation. But if you want to maybe have a colleague watch the presentation, feel free to send the link. It's free of charge. We're not trying to make any money off of it or off Dr. Marson. So just watch for an email to come through if you've been in some of our webinars, and you'll be able to then share that if you'd like with colleagues. So with that,